Last time we looked at the ethics involved in COVID-19. We looked at the first scenario, which is ventilator shortages. So if you remember back in the pandemic, on the news everywhere, there weren't enough ventilators for those that are in critical care that require support and assistance in breathing, because coronavirus, the COVID, was creating too much of a swollen air ducts, a reaction to contracting the disease, right? Before we slowly evolved to be able to deal with it, as well as vaccinations being put into place and mitigating public health issues through other means like physically reducing transmission through masks and all other kinds of strategies like that. So last session, that was ventilator shortages. This session, we're going to look at something called elective procedure cancellation, okay? So cancelling elective procedures during the time, both kind of during the pandemic and slightly after the pandemic, there was a backlog of non-essential emergency procedures, medical procedures. So can you think of any examples of procedures that can be not emergency but still required? So for example, something that didn't cause like a very time-sensitive danger to life. If there was a condition which somebody had that required care or some kind of support with, that wasn't life-threatening, but if left for a long period of time, would develop to become worse.
Yeah.
Okay, that's what we're talking about, right? But some heart surgeries, for example, or even cancer, because it's not immediate. It's not like we're talking kind of like within a few months somebody's going to pass away if they haven't got treatment.
But over time, if it's not treated, then it's going to.
Exactly. So that's on the worst end of the scale, cancer treatments and support, as well as things related to the heart as well, for example, right? So obviously, if you've got a heart condition, it has an impact on that person's quality of life. Last session, we looked at something called QALYs, which is a way that we put value to the quality of life. The next thing I was going to talk about was an example of the impact on health. If it's left longer, it gets worse, right? And so therefore, reducing somebody's QALY. An example of that happening in my personal experience during the pandemic and the lockdowns is I actually had a deep root canal in one of my back molars. Mm-hmm. I chewed into something and it snapped the tooth, and a bit of the actual filling part actually was removed with the thing that I was chewing. It was like some sort of toffee thing, right? It was painful, right? And so I had like a large gouge kind of like of my tooth that came out and the filling. So then I had to just wait months and months and months until like I could actually see a dentist in order to try and repair it. And in the end, I ended up having to lose a tooth because too much time had went past for them to be able to then kind of save the tooth, because a certain amount of decay happened. So I remember I was just cleaning my teeth crazily all the time. It didn't help.
Yeah, was that because it wasn't deemed as important as like?
Yeah, it was a non-crucial emergency procedure, right? So so that's an example, right? Another example. So many patients were waiting months for elective operations and procedures. So how is quality of life valued in an emergency situation?
So like in an emergency situation, so it's like if it's a surgery where you can like either save the patient or not, like you're going to focus on just saving the patient, like as it is right then and there, while you're also trying to like remain, like keep their quality of life how it was before the surgery, but ultimately you're trying to keep them alive.
Yeah, you're preventing them from maybe passing away, right? Yeah. So the quality of life at the time in an emergency situation is valued as to whether or not they're going to have a significant amount of time afterwards of survival, or whether or not it's a very short amount of time. And if it's a very short amount of time, if there's a procedure that has to take place, then that's something then they deem as more urgent. Mm-hmm. So there's that, but then they also need to value whether or not it's worth. So we talked about ventilator shortages last time, where there weren't enough resources per people.
Yeah.
And then how do you measure the importance of using that resource on particular people? So if you've got one ventilator and you've got 2 people, what do you do? And so a really horrendous decision has to be made of whose life has to be placed with more value in order to get that resource. Okay, and that's where something called QALYs comes in, the amount of time that you're going to have, adding to society at a good enough quality of life relative to the other person.
Because if you look at it, there's like someone who's like almost near death, and if you put them on a ventilator, it's not going to impact them as much, rather than like say someone who's healthier and
it has more years of healthy life in front of them. Yeah, exactly. Okay, but then there are a range of other factors that are also at play there, right? So, such as who are we to say and determine that somebody is going to add more or not? And maybe somebody who lives for a shorter amount of time at a lower quality of life may actually be more effective in doing certain tasks and giving more benefits to to the society.
But then eventually you have to put like a limit toward that, because then you have so many what ifs. But then eventually you have to have like a boundary.
Yeah. So you're saying it's important to have a kind of some kind of rule or objectivity in place that everyone can follow. Absolutely. Yeah. Okay. So elective procedure cancellations. During the pandemic, it's you're in a critical situation. Okay. So the best way to prevent new cases and to improve the rates of survival in the population is for the whole population to bring whatever resources that are available together to combat the pandemic. So in terms of that, if you remember, there was a lot of scrabbling around like internationally over making sure there was enough PPE, personal protective equipment, in order to try to prevent the spread, and then do something called lower the curve, which is also, you'll see in the previous video where we talked with graphs on kind of what that means, because there was always a lot of talk about kind of like lowering the curve and reducing the, and spreading it out over a longer period of time. So the idea of public health systems and viewing kind of like large numbers of people and what benefits the greater good needs to be considered. So that's what this concept of in this together. So as a result, those people that would benefit from certain procedures also have to think about the greater good, and that is reducing the number of death rate, or the death rate relative to the importance of their procedure, and they have to in effect take a hit, or or have to prolong or wait for a certain procedure that's not life-threatening to them. So non-emergencies. Elective surgeries are not emergencies. To continue with elective surgeries would have meant a significant amount of resources. If you remember, there weren't a lot of resources in terms of people and staffing and those supporting general healthcare, right? So, so the workforce, in effect, is a major resource in a pandemic. And so for them to be taken away from dealing with the pandemic and be dealing with non-essential or non-emergency procedures, treatments, would have reduced the amount of resources that were available to try to support the greater good, at the time. So this workforce and resources could otherwise be deployed to help the patients that are suffering from COVID-19. The NHS may be unable to cope with the pandemic without these extra people from different areas in healthcare supporting this area in healthcare. Okay. So quality of life. Elective surgeries can have a significant positive impact on quality of life. Therefore, the qualities that are gained, which means the quality years, okay, so if the elective procedure may occur, that may improve somebody's QALY. It's a number that's given to each person between 0 and 1. And so if you're at 0.5 and then you have an elective procedure, and that increases maybe to 0.6, that has a significant impact on the life of that person, or even above 0.6, just as arbitrary numbers, okay? So the QALYs that are gained for those patients may be greater than those by diverting away from the extra support of resources and manpower and the workforce on the COVID-19 for that person.
It's such a gray area, because then you're like, what if you don't necessarily know exactly, like...
Yeah, you're right. It depends on what unit of measure you're using to then justify whether or not that it will give a more of a benefit to that person or not. Yeah. So the idea of fairness then comes in and subjectivity. Okay. Many patients have been waiting for their elective operations for many months after the pandemic. And in fact, some people, a good year or so. I didn't see the dentist for since the lockdown had finished, because then there's a great demand for those same resources, right? So I think it was about 6 months to a year until I actually got it seen to. So obviously by that time, my tooth is not going to be in a very good position, right? Is it right to make them wait even longer with greater uncertainty if and when they'll have their surgery? So coming back to my tooth, I kind of knew that I just had to, in effect, suck it up and wait because it just wasn't feasible. And losing a tooth is not the same as kind of like losing the functioning of a vital organ.
Yeah.
Okay, but there's also the idea of a patient risk. Okay, so it's well known that infections can spread rapidly through a hospital. So if you're having surgery and there's also COVID-19 in the hospital, and because it was so highly infectious, there's a massive increase in risk in those patients that are needing these non-emergency situations or operations. Okay. So all surgeries and the associated hospital stay, that means the time before and after the operation, have the risk with the COVID-19 pandemic. And the longer they stay there, the longer the risk, the more risk there is. It increases over time. So that increased risk stems from the likelihood of them catching COVID-19 in the hospital, as well as the limitations on the resources that it would be available if complications occurred during the surgery and the patient required critical care. What that basically is saying is something that wasn't essential to start with, some kind of operation, A, took away people to do that operation to start with, away from the pandemic, and B, if they contracted the virus, then they may actually increase the need for the resources of the ventilators and all the other periphery things that were trying to be put into place. Exactly, snowballing kind of issue, right? Let's watch this video with an example, a case study.
The Beresford family are making the most of a walk in the local park. 15-year-old Guy has a heart condition, so from this weekend he'll be staying home for 12 weeks. And there's another worry. In January, doctors diagnosed another condition, arrhythmia, which means his heart is at risk of stopping suddenly. He was booked in for surgery to fit an implant today, but last week they got a phone call.
The hospital, unfortunately, one of the team contracted coronavirus, tested positive, so they had to shut the cardiac ward.
They're waiting to hear when the operation will be rescheduled.
I was not looking forward to having it done, but I wanted it out of the way, and it was nice having a date for when it was happening, and obviously that not happening, and now I have no idea when it's happening, and obviously the risk of cardiac arrest is a worry.
Which causes anxiety.
It was already hard
mental
enough
health,
as it
and
was
range of other
without
things.
this on top, which is obviously a worry for anyone.
And so, into the unknown. Karina has taken Guy and his siblings out of school already, before the stricter measures set in.
It's still a bit strange not seeing my friends.
It's a weird sensation. I think you said it best yesterday, and you said...
Everything's wrong, but nothing's wrong.
Yeah.
The Beresfords, like so many other families right now, feel in limbo, and there's nothing they can do to change it. Tessa Chapman, 5 News in Hampshire.
Right, so the summary of the arguments. Elective surgeries can have a huge impact on the quality of life. So, therefore, they are a means to act beneficially. COVID-19 increases the risk to patients in the hospital setting. That means postponing elective surgeries would help to avoid doing harm. During the pandemic, the benefits for an individual must be balanced against the potential harm done to the whole population if resources are diverted away from the COVID-19 efforts. here's our next scenario related to the ethics involved in the COVID-19 pandemic during the time. Dying alone in hospital. If you remember, there was a time where a lot of people were being told, in fact, no, everybody was being told, if somebody's in hospital, a family member, then it's not okay due to the lockdowns and trying to prevent the spread, for the family to come in and to be by their side as just before they pass. Okay. So due to the infective nature of COVID-19, they were banned from visiting dying patients, the relatives were, in many hospitals. Now, the question is this right? Okay. So due to strict control measures, many hospitals closed their doors to visitors. Therefore, many of those in hospitals, including the patients, died alone without their family members by their side. Is it right to deny family visits at the end of life, do you think?
So I have sort of like a story about this. It wasn't about my grandpa. He wasn't towards the end of his life, but he was in like critical condition with pneumonia in the hospital during COVID-19.
So there was massive uncertainty there for your family, yeah.
And so my family were trying to go and visit because obviously they wanted to see him, but they wouldn't let my family go into the hospital because they said they have a chance of either harming him even more, so like where he could go in even more critical condition because they could bring something in, but also there's family, and like if he was going to pass on, then they wanted to see him. But it was eventually they like let one of my family members once a week go in like a whole like gown, like suit and everything. So I guess you could take like safety measures to go in there, but I also think it's also somewhat right to deny them to go in because it could either harm more or it could lead to just,
especially if they're in critical care, because then the other people in and around the critical care unit could also be exposed to more.
But I also think like you could at least have like at least the patient in a separate room, but have like some like sort of like where they have not a prison, but like where you can speak to them at least. Like I think they should
some
be able
sort of
to
speaker,
how it's like you see them through a glass thing.
So putting in kind of effective safety measures in order to kind of mitigate the issues or the harm that everybody was concerned about it causing, But then even just the act of walking through the corridors is also another.
Exactly.
It could be argued on the other side, But so there is no right answer, right? That's the point, right? However, it's it's not easy for either side. So optimal patient and family care. As doctors, we want to provide the best possible care to patients and their families. This is as, if not more important, at the end of life care. So we need to balance the positive benefit of having family present against the potential risk of exposing them to COVID-19 and others. Because there is, after all, a unique value that's placed on family as humans, okay? And so, like, many of our closest relationships are with our family members. So therefore, it's no surprise that these people want to be surrounded as they pass away with these members of family, okay? Because they can provide comfort and alleviate any kind of suffering during that whole dying process.
Which is a valid point,
Absolutely, because we are humans, right? And we are social creatures, and you have a whole life in and around and intertwined with these particular people, right? So dealing with grief, the families of those that are deceased may be better able to cope with this grief, right? I mean, it seems quite a removed experience when you're told by somebody that one of your family members has passed away, yet you're still unable to be there in those moments or be in and around those people that have been around in those final moments, right? It kind of, it feels very surreal, right? If they are able to be there to give the support to their relative as their relative dies as well.
I guess that's why they have hospice.
Exactly, hospice and palliative care and all of these other things. And the greater good. So the cost of dying alone. So here we are trying to weigh up each kind of, side of the argument, all right? And that's what you need to do when you're dealing with questions related to medical ethics in the interviews. Okay.
Yeah, like the pros and cons and which one will outweigh each other in the certain moment.
Yeah, both sides of the argument. So we went through this like in the middle of the last session when we first started the COVID-19 scenario. So where we talked about kind of the two sides with supporting evidence and then tried to find some kind of like balanced conclusion, right? So the greater good, so balancing that out, the cost of dying alone to individuals and their families must be outweighed or must be weighed up, against the benefit of the population as a whole. So now we're going to just kind of explore a case study with that as well here. Okay, so there's a boy, this hit the news during the time of the pandemic. There was a 13-year-old boy that had to die alone when he contracted the virus. And there was a lot of discussion and a lot of debates in and around this at the time. So here's the news clip that explored, or one of the news clips that explored that.
Ismail, anyone who met Ismail would tell you straight away. He was a young boy that would make you smile, really full of life, really full of joy. I've met him and his family a few times, and he's someone that is young and very patient with how you deal with him. Doesn't, if you become frustrated with him, someone that maintains his patience and is just there to make you smile. It never says no to whenever his families will make requests. Had extreme respect towards his mother, extreme care towards his family members, great passion, great interest in buses, modes of transport. So I was speaking to his sister, and she was mentioning that whenever she would go out to travel, he would always inquire what kind of mode of transport they're using. It was an interest for him. Loved animals. In fact, when the paramedics came to sort of take him on the night that he became ill, they asked him, what do you want to go do when you grow up? And he mentioned, I want to be a vet. So he had these interests and he had these passions, and you can tell that he was just a caring, loving individual. Because of the need and the way that this virus itself is, no one else is allowed to be around that individual. And that means you're on your deathbed in your last moments alone. And he was a young boy, age 13, without his mother, without any sibling on his deathbed in the last moments. And that's very hard to sort of digest. The family has yet to be able to grieve. They're yet to bury the Ismail, and they're yet to sort of be able to close this chapter. And you can imagine, because of the virus itself, not being able to witness his burial, not being able to just deal with it very rapidly and quickly, having a lot of inquiries. The families, I'm sure they just wish that this is a nightmare that they wake up to realize it's not actually real, and that's how it must feel like for them.
Okay, so I think that kind of explores the points that we were making in quite an impactful way, right? So the summary of the arguments: dying alone could cause significant distress to the individuals and to their family members. Therefore, this could cause harm, right? Maleficence. Yeah. Preventing visitors from entering the hospital reduces the chances that they will carry COVID-19, both in the hospital and back outside into the general population, therefore reducing the potential for harm. So preventing visitors also reduces the risks of the visitors themselves becoming infected. Okay, so this is our final scenario. Returning of retired staff. You may have remembered that there was a time where the amount of support staff that was available wasn't enough to, obviously, like we were saying before, the resources and the people involved weren't enough to combat the rising amount of people and the amount of kind of effort and need to kind of support the efforts. So to cope with staff shortages and sicknesses, many of the retired staff were asked to return. However, the issue at stake and that we want to consider is this is an at-risk group. These are people that are retired, and if you remember, it was those with existing health conditions and those of older ages that were at greater risk. Those retirees, even though their skills are needed, is it right for them as people to be coming back? So in light of those shortages, they were being brought back, many at retiring age and therefore at high risk. Is it ethical? And should they be encouraged to return or not be encouraged and just asked? Nice. I mean, like, where's the line? Yeah.
That's true. I mean, some of people could view it as like a form of like altruism. I think that's the word, where it's
That is the word, yeah.
It may not be the best for you, but it's like the best for your community in order to help work out. But then again, it's going to maybe harm a part of like the older population's community because they might gain COVID-19. But
And also, is it increasing the possibility to spread as well because you've got somebody else contracting it? And then also, is it the ultimate altruism in the fact that some people might unknowingly, or they're at risk of, sacrificing their own lives in order to do a drop of good to help the greater good, in effect, right?
I think it's ethical if the person gets to choose if they want to come back.
Okay.
So, like, you have a right to say, I want to go back to work. So if they feel like they have an obligation to themselves to go back to work, then it may be ethical because that's their choice, I guess.
Of the 4 pillars, what does that tie in with? I'll go through them. Okay, you've got beneficence, non-maleficence, justice, autonomy.
Isn't it autonomy?
Yes, autonomy, giving them the right to choose. Yeah. Okay, so the staffing issues. As the pandemic infested, so did the amount of staff sicknesses. Many units were reported at 50% levels of staff sickness. Okay. Now, some of it was because people are concerned and don't want to go in, or they're overly worked and stretched and stressed out. I mean, there's a whole reason why they're off sick, as well as actually getting the virus as well. Okay.
Yeah.
So understandably, it's difficult to staff. A safe department or wards that they may normally be in, and then to be off sick, and then all of a sudden now they become sick because they're not in that safe environment. But where can we get suitably skilled trained staff from, right? Where else would you find those people? You can't train these people up, or new staff members. It takes a long period of time to get trained, right? It's difficult to find what the most suitable situation is, yeah? Chronic understaffing isn't a factor to think about, right? So it was already understaffed, the NHS in the UK, before the pandemic. And then during the pandemic, it obviously became much, much worse. It wasn't able, it was considered that it will not be able to function without these additional people coming in to return to work. Now, do remember, some were not, some people may have retired and gone into a different career. Okay. Due to the prevalence of the disease, many of those workers, including those that were older and more at risk, were needed on the COVID wards themselves.
Yeah.
Even though there were other places and other means in which they could support the general work on trying to improve the public health. So volunteering, returning to work during the pandemic has an element of personal risk. This ties into what you were saying, giving them some sort of autonomy. Individuals must not be forced or pressured to return to work. They must be asked to volunteer, okay? Prioritizing staff safely as well. Those members of staff that were at higher risk due to their age or other health conditions shouldn't really be put on those wards, should they? But could be deployed in low risk areas like oncology, right? The staff in those lower risk areas could then be redeployed into the wards. So these retired people go into less risky situations or wards or efforts, right? And those that were already in those less risky areas can then be deployed into more riskier areas. That's the argument there, right? Or alternatively, the most vulnerable staff should be given priority for PPE, because there wasn't enough PPE at the time. And honestly, during the whole of the pandemic, I did a lot of research on different types of masks and so on, and I genuinely didn't feel that the stuff that they were saying, oh, it's fine because they've got PPE. I mean, when you look at the size of the filters relative to the size of the virus, I mean, really, we're talking like a virus is 0.03 microns, right? And those holes in which to get air in to breathe were far greater than that in the majority of the PPE, right? Those little surgeon masks, they don't do anything.
Yeah, during at my old school in Paris, I'm in band, and it was still during COVID, and they decided to cut holes in the mask so you could play your instrument. But you know, since you have a mask on, then you're stopping COVID from coming.
It's more like psychological, and that's why there was so much research coming out saying the science is in, and wearing a mask doesn't actually reduce the risk. It's more psychological.
Yeah.
Well, yeah, that's because it's A, the wrong mask, and B, you've also got to make sure it's sealed all the way around your nose and then to the front. So like some I found that like the shape of my nose relative to my cheekbones and so on wasn't necessarily, like, all of the masks that I was using weren't necessarily as sealed as they could be, right? So I spent a lot of time buying a whole range of different masks to make sure I could find one that was more sealed, right? And there was like the N99s and the N95s and yeah. Okay, so this guy, do you know who this guy is?
Matt Hancock.
That's right. And he was, at the time, he was the health secretary, okay? So this is the news clip where he's actually asking to pleading to bring back those retired doctors.
With coronavirus growing, on Friday we put out the call asking recently retired doctors, nurses, other health professionals to come back to the NHS to help in this unprecedented crisis. I'm delighted that in the first 48 hours, 4,000 nurses and 500 doctors have already signed up. But we need many more. It's easy to do, and we will make sure that your service is put to best effect. The whole country needs the NHS right now. And if you're a retired doctor or a retired nurse, then your NHS needs you.
It's easy to do, huh? Not if you consider the ethical implications. Those masks are better.
In the US, it wasn't in the NHS, but one of my grandparents' friends was a doctor, and he decided to go back and work at the hospital in the COVID ward, but then he ended up getting COVID himself. So. Yeah.
And was he critical, or was he okay, or?
He was okay, but it's sort of.
It's a risk, right?
Yeah.
So beneficence versus, right, so back to the whole calling in the doctors and nurses, healthcare workers. Let's look at this in terms of the lens of beneficence against non-maleficence. So there is a risk of doing harm if older members of staff, usually those who are most senior, do not see critical COVID-19 patients. A balance must be found and was attempted to be found between the potential harm to the more vulnerable staff members versus the risk of the COVID-19 patients receiving that senior input and support, okay? Many retired medical professionals felt a sense of duty to return back. However, this may be putting themselves and their families more at risk as well. So you've got the beneficence of they're coming back and duty bound and giving the wealth of their experience and knowledge and support. That's the beneficence. But then the non-maleficence is, well, we can't let the patients potentially be at risk, but also this may be putting themselves and their families at risk. So we can't put these retirees at too much risk as well, especially without the adequate PPE, which we've explored. So there is a link there, which if you're watching the video, you can type out, pause the video and type it in just to have a quick look. It gives the effects on how age affects the prognosis of COVID-19. Okay, it was an article from the British Medical Journal.
NHS medics are dying, and Dr. Alpha Sadhu is one. The Nigerian-born retired medical director spent his whole career in the NHS and was also a devoted grandfather. He was working with elderly patients just 1 day a week with no protective equipment, yet still managed to catch the virus. His condition deteriorated on Sunday after 2 weeks of staying at home, but he resisted using up stretched NHS resources.
We said goodbye to him, not knowing that that would be the last time we'd see him. And after that, from Sunday evening to Tuesday morning, he just deteriorated. Body shut down, organ failure. I've never seen anything. You know, both my parents are doctors. I'm quite experienced or quite experienced with different diseases and viruses that are out there, but I've never seen anything like this.
7 unions have called the lack of PPE a crisis within a crisis, saying medics are being exposed to unreasonable and unnecessary risk by the failure to provide adequate PPE. Several doctors have told us about their worries.
Unlike a lot of the military rhetoric which is happening right now, we're not soldiers that are trained for war. We are ordinary human beings who have families, who are terrified for our safety. And we are terrified for their safety, because the reality is that we could be bringing this virus home to the people that we love most.
Many health workers are buying protective equipment themselves or getting donations, amid claims that complaints directly to the media are met with threats and pressure to stop.
We've been hearing from frontline doctors in their droves who have concerns about personal protective equipment, about the lack of testing of frontline staff. And as they've raised these concerns locally, they've essentially been gagged by either managers or senior managers within their organisations. They're being told that their social media, for example, is being monitored, and that if they were to raise concerns, that in some cases their jobs and positions will become untenable.
For Dr. Sadhu's family, the loss is immeasurable, and his son Danny warned others to take the virus seriously.
I remember when Boris Johnson said on the news a few weeks ago, he said, you know, be prepared to lose loved ones. And at the time when he said it, I got really angry. And I just thought, you know, this is not a movie. Why are you saying this? You know, you're over-dramatizing this. And I now understand what he means. I've learned the hard way. People really need to take this seriously. This isn't a joke.
His father is viewed as a hero by many, one of an increasing number. But behind all these statistics are real people, real lives lost, leaving real families behind. Alex Crawford, Sky News, North London.
Okay, so now I just want to go through some potential examples of interview questions that you may get. Okay, so there have been a lot of, so these, I'll literally just read them out, okay, and just so you're kind of like aware of some examples that can happen. All right, so some additional questions. There have been reports of significant shortages of PPE for medical staff. Even with correct PPE, staff are at risk of contracting COVID-19. What were the ethical implications of this? Okay. Based on what we've been through, based on looking at the 4 pillars, based on then looking at the idea of kind of the 3 C's and a whole range of other things, this is what we're looking at when we're dealing with these interview questions. Putting unconfirmed cases of COVID-19 together on a single ward increases the risk that the unaffected will become infected. Is it right to put others at risk in this situation? The next one. Several existing medications have been suggested as possible treatments for COVID-19 patients. However, there's a limited evidence based to support the use of these medications in this way. Should we try these treatments or not? So it comes down to the idea also of there's a life cycle when you're dealing with research and testing of new drugs in the system, and they take a very long time to go through. And the reason why is because of the reducing the amount of munificence that can occur through side effects, harmful side effects, and so on. Okay, so that's where the argument is the benefit going to outweigh the negative or the side effects? So it's actually too much of a kind of a risk of kind of deciding which ones are going to be more beneficial and which ones aren't going to be beneficial to the individual people, participants in the experiments, basically. So it's that whole kind of discussion of balance and counter weighting that as well. A GP surgery in Wales was criticised back in the pandemic for sending out letters to encourage older people and those with significant pre-existing health conditions to agree to DNACRP forms. That means do not resuscitate forms. What are the ethical implications for CPR and taking these extraordinary methods in a pandemic setting? So it comes to the idea of trying to protect public health by reducing the amount of spread. So if somebody needs CPR, then obviously they're going to be in close contact and increase the risk of spread further. Okay. So just some examples specific to COVID-19, right, that could have been used in an interview. So summary of medical ethics. You must display balance. Always argue both for and against points. Use the 4 pillars to help generate your arguments. Always come to a balanced conclusion after having considered all angles, and remember, there is no right or wrong answer, just an incorrect way of approaching this. And the incorrect way of approaching it is not looking at 1 to 3. Okay, so thank you and good luck. There may be medical tools in your hands to treat the patient, but those hands must be ones that are loving, warm, and conscientious human beings. Nice little quote there to finish. Okay, and so that really summarizes and sums up the end of our ethics. Thank you very much, everybody, for watching and coming and being engaged in this. And do remember the videos are there for everybody to kind of readdress and look over points and to refresh and remind yourselves. These are crucial in UK medical applications for the interviews, but also are a must need for all healthcare professions or future healthcare professions that can understand the ethics behind pretty much most decisions that happen in any kind of healthcare setting. And thank you very much, and good luck. And don't forget to make sure that you're getting your work experience in place, ready for this summer. Take care now.